Our next speaker will be Paul Phillips from the University of Arkansas with a talk entitled My Eye Bulges and I See Double.
I have no financial interests or relationships to disclose. A 76-year-old man, 1 month prior to presentation, noted some bulging of the left eye and a swelling of the left lower lid. 2 weeks later, he developed binocular intermittent vertical diplopia that was worse than down gaze. His local physician ordered a CT prior to referring him that showed an enlarged left inferior rectus muscle, and he was referred for treatment with a diagnosis of thyroid eye disease. His past medical history was significant only for a basal cell removed from his right lower lid. He reported some nonspecific mild fatigue for several months, but otherwise denied weight loss, palpitations, fevers, night sweats. He was otherwise healthy, no medical or tobacco use. And on exam, by the time he was referred to us a month after the onset of his symptoms, he was alert, afebrile, 20/20 vision both eyes, confrontation and Goldman visual fields were full, pupils were equal-reactive, no REPD, slit lamp and fundus exam was normal, and fundus torsion position was normal. Here are his findings. He did have a mild amount of proptosis, 1 to 2 millimeters on Hertel, and he's got some fullness of the left lower lid. On motility, he had a mild limitation of down gaze. These were his measurements, very tiny left hypertropia that did increase in down gaze. Whenever I evaluate a vertical strabismus, I always want to look at the torsional position of the eye, and I evaluate that by looking at the fundus with the head held straight, and a horizontal line through the fovea should intersect the lower third of the disc, and in this case it's normal. The fundus position was normal. If the rectus or oblique muscles are malfunctioning, often the torsion position will be abnormal. He was referred with a CT, a large inferior rectus muscle. And the first question I want to direct to the panel before going to this specific case is, what is the role of neuroimaging for the diagnosis of thyroid-related orbitopathy? Do you order it on some, on all? And if so, what's the best modality?
Well, is this thyroid-related
Yeah.
ophthalmopathy? Maybe
Well, we'll get to
discuss
that. But my first question is there any case where someone appears to have proptosis, clinical findings with ocular misalignment? Will you ever make the diagnosis without some form of imaging of the orbit?
I don't.
No. I mean, there may be a few centers where the level of echography is strong enough to do that, but that's not what most of us encounter.
But I do think that a CT scan probably is as good as an MRI in this kind of setting. So if you have someone who's claustrophobic or you don't want, they can't have gadolinium for some reason, I think this is one of those cases where a CT is pretty good.
But how about, let's say, a typical 30-year-old hyperthyroidism, proptosis, otherwise normal exam? Will you still obtain imaging? Will anyone not image a case at all?
I mean, I think in that case, you're still looking for compression, potential compression of the optic nerve or imminent compression, so you'd want to follow them more closely. So I think you want to know.
Okay, so the consensus is image all, even with typical thyroid. Now,
Well, you want to make sure that you have more than one extraocular muscle involved as well.
okay, so that's a good thought. How about for treatment? Mike, a strabismus surgeon, will you use the findings on MRI for decisions about strabismus surgery?
No. I use the motility and the alignment pattern.
Okay. So let's get into this, moving to this patient. What do we think's going on here?
Can you qualify here? So that was a left inferior rectus that was large, correct? But you said he had a right firmness under the right lid?
No, left lower lid.
Okay.
Left inferior rectus, left lower lid, and he's got the left eye does not depress fully, and the left hypertropia and down gaze, all on the left side. So is this consistent with thyroid? Does anything trouble you here?
No, it's reversed. I mean, if you have a large inferior rectus from thyroid orbitopathy, you'll have a restrictive strabismus where you can't elevate. So the greatest deviation would be an ipsilateral hypotropia in the opposite direction. So this is actually a underfunctioning inferior rectus, which is not at all consistent with thyroid.
Yeah, the last patient I had with a clinical similar scenario with enlargement of the inferior rectus and firmness had lymphoma of the inferior rectus. So I'd be thinking more about an infiltrator process affecting the muscle rather than thyroid eye disease.
And again, maybe right-left confusion, but you told us he had a right basal cell removed, did you not?
He did have a right basal cell. You can kind of see the scar over there, correct?
Yeah.
That's the
So-
only thing on the right side.
So basal cell doesn't usually do the creepy crawly. It can, but perineural spread is usually squamous cell, but you can have it with basal cell. But what's more important is that the same complexion and risk factors for a basal cell would be for a squamous cell, and there may very well have been another one on the other side, and you are getting creepy crawly. Now, did he have any numbness? Because typically perineural spread goes with the branches of the sensory nerves before it would involve the motor nerves.
Yeah, he did not have any numbness.
And I didn't look at the infraorbital nerve on the MRI imaging. It went too quickly, but if V2 are involved, you might think of IgG4 as another process that will infiltrate the muscle.
Now that we're thinking that this might be something other than thyroid disease, does it change our mind whether we want to do a CT scan or an MRI scan?
I mean, to some extent, you can tell the type of process maybe a little better on MRI, and certainly you could see the inferior orbital nerves better on an MRI. If it's a metastasis, you would get more of a lumpy, bumpy appearance, but you'd see that on CT too.
See, one other thing that can look like this, both motility-wise and image-wise, is orbital myositis, but typically they would have a lot of pain or injection during this paretic phase. But so that doesn't fit with it, but it, have to be very atypical to be in the differential.
Yeah, so he did not have any pain, injection, redness, or other signs of orbital myositis.
When you looked in the lower lid on the conjunctival side on the left side, was there anything like a mass?
No, not on the external slit lamp exam.
Why don't we continue with the case?
All right. Well, we mentioned he was referred, we already discussed the issues with thyroid, most common cause of acquired proptosis, women more than men, cigarette smoking is a risk factor. They typically have proptosis, lid retraction, diplopia, and as been noted, if you have an enlarged muscle, you should have restriction. So I think one of the most atypical things in this case is that the supposed enlarged muscle is weak, and thyroid dysfunction occurs in many, but not all. And in this patient, we were concerned that and suspected it was not thyroid, as he had no lid retraction. Only one extraocular muscle was affected. This was a very important point that Mike mentioned, that there was reduced inferior rectus function. This pretty much rules thyroid out. He had a left hypertropia, whereas thyroid virtually would always cause restriction, and a left hypotropia. Fundus torsion was normal. A tight inferior rectus muscle should cause extorsion. And the lid was, in addition to being a little swollen, was a little firm. So, what now?
Well, I'd
I
look
think
at the
biopsy.
Yeah, I'd look at the MRI again and see if there was something easy to biopsy, like an infraorbital nerve, and then otherwise you need tissue.
All right, so that's a great point. And this is actually at the referral. This is the scan that was sent electronically. But once I got a hold of the full CT, this is normal, this is his CT. You can see there's actually a mass adjacent to the inferior rectus muscle creeping into the left lower lid. Whereas, this is a normal eye where you can delineate the inferior rectus and the inferior oblique. He clearly has something growing over there. So I think the next course is biopsy.
Biopsy.
Well, indeed, that was done, and he had a diffuse B-cell lymphoma. He was treated with radiation and chemo and had resolution of the lesion. So there's before, there's after. So he did very well. So once again, orbital lymphoma can mimic thyroid. Most are B-cell of origin, typically in elder patients, equal gender distribution, multiple histologic subtypes. On imaging, it often molds to orbital structures, and treatment as in this case, excision, radiation, and chemo. And I think the take-home point, it's also unilateral. The eye findings have some overlap with any orbital process, proptosis, limited motility. There can be pain, lipedema, ptosis, chemosis, and only a minority have systemic symptoms. So I think the take-home is that not all proptosis is thyroid. We always learn acquired proptosis is thyroid-related orbitopathy is number 1, 2, or 3 on the list. But there is a differential. It sounds like the panel is all for orbital imaging in every case. And in this case, the fact that he had no lid retraction, only one muscle, reduced inferior rectus muscle function, normal torsion, as well as firmness of the lower lid, showed that it was not thyroid. Thank you.
We had some questions from the audience. The first one, how common is superior rectus and oblique enlargement in thyroid orbitopathy?
Superior rectus is the third most common muscle. Inferior and medial are the second. As we've had better imaging evolve through the last 10 years, both the superior and inferior oblique can definitely be involved.
Yeah, I agree. We've seen enlargement of all the muscles, and sometimes that could help your strabismus planning. So, Mike, I was a little surprised that you don't use it at all in planning a strabismus surgery. You could have a tiny deviation, and if you have a large superior and a large inferior in the same eye, if you loosen that inferior just a little bit, you're going to get a huge overcorrection.
Yeah, well, maybe you're better than I am, but, I want to make them see straight, single, down gaze. I don't want to mess anything up, and, I wait a long time to make sure they're stable, make sure it's not something I can treat long-term with prisms, because, the goal is you want to make sure that if you can, you get this done in one time. And, it's so unpredictable sometimes operating on thyroid, and I find that the less I can do, the better off I am.
Another question, does a paretic large rectus muscle, as opposed to a restrictive one, always require a biopsy?
I'll turn that on its side a little bit and just say that this lymphoma or a MET or anything else involving the inferior rectus most often still will cause a restrictive. So what you're saying is true, that it would be extremely unlikely for thyroid eye disease to have a paretic muscle. It's still, most of the time you're going to have a restrictive one. But I haven't answered that question. I'll let the orbital people do that.
Yeah, but if it is paretic and enlarged, does that push you more in the direction of biopsy?
Oh, yes.
Yes.
Unless it's typical orbital myositis with pain and injection, because
Right.
the time course is the first 3 weeks of orbital myositis is paretic, and then if it scars, it becomes restrictive.
Yeah, my experience with myositis is the same, as it can be paretic, but there'd be pain, injection, and in that case, you might do a trial of steroids without a biopsy, correct?
Another person wanted to know what you think about thyroid-related orbitopathy without any eyelid changes at all.
It happens. I mean,
Again, I think it's like the first case, it's the proportion. You got a really big inferior rectus muscle and no obvious lid changes, so it's out of proportion, so that's atypical.
All right, thank you very much.
Thanks.